we've got hands with Mr. Dan Williams, who is a consultant hand and upper limb surgeon at Whipps Cross Hospital, part of Barts at Bone and Joint. And we've also got Mr. Carpal Alignment, who is a post time and grace fellow at Pulvertage Centre in Derby. And Mr. Williams will be starting the talk with hand trauma, and Mr. Vergella will finish the talk with hand elective. So off to Mr. Williams now. Thank you.
Oh. Okay, hi everyone. As Shamini said, my name's Dan Williams. I'm a consultant at Barts and I work at the Royal London and at Whipps Cross. We're very lucky to have Kalpesh, who was my trainee for a short period, but has left to go on to bigger things in Derby. So I'm just going to start with a little bit of an introduction. And as we said, I'm going to run through a few sort of common hand and wrist injuries, particularly distal radius fractures, scaphoid fractures, and acute carpal instability. Now, you may think these things are really common, but it's pretty important to have a pretty thorough grasp of these injuries as you move from sort of your core surgery and SHOs into registrar training. And then Kalpesh is going to go on to a bit about infection and common elective problems. Now, just trying to check that I can see the chat box. Just in case anyone wants to ask any questions, they can ask them at any point. Just message in the chat box and I'll see if I can get to you. Okay. So top right is the Royal London. Bottom right is what Whipps hopes to be in the future. And on the left is the Princess Alexandra Hospital in Brisbane. And this is where I spent 2 years in a fantastic elective and trauma hospital in Brisbane. And I'd recommend visiting or going over there to anyone who gets the opportunity. And, you know, as a disclosure, most of these ideas have come from one of these places, and there's a few of their ideas in the talk. Now, hand and wrist is a massive subject, and it's almost a specialty on its own within orthopaedics, and is combined with orthopaedics and plastics, who in most places work very closely together. It covers open trauma, bony trauma, soft tissue trauma, infection, deformity, joint replacements. We use microscopes, we do flaps. So it's a really diverse and interesting topic. And one of the reasons it's so interesting and diverse is because it's so important. Pretty much everything we do in life revolves around us using our hands. And it doesn't take much of an injury or an impairment to really massively affect our function and our fulfillment. And with that in mind, everything we do in hand surgery is designed to keep our hands moving. When you fix a fracture, you've got to move it straight away to try and regain motion, as hands don't like not being used. They get stiff very quickly and we end up in big problems which are hard to treat. Now, as SHOs and core trainees moving into reg jobs, you're expected to recognize that there are a number of hand and wrist emergencies. Now, most of you have seen some things like this. The one in the middle with being shot through the arm is a very obvious emergency. The one on the left, Kalpesh will talk a bit more about, but this is a life and limb threatening infection of the hand. The one on the right, a lot of you would have seen and be obvious to you, but many of you won't. And this is something that we'll hopefully cover a bit more in detail today. Oh. So we're going to start off talking about distal radius fractures, which is sort of bread and butter stuff, but there's quite a lot of intricacies that I hope to point out to you today. So I'm going to start off asking about, you get a sort of idea of what you guys already know, just going through a few simple or a few cases. So can we start with question number 1? Shamini, can we put that up? There we go. So basically, I want to know for this fracture, in a 70-year-old gentleman who's pretty fit and well, who would just put it in a cast? Who would put it in a cast on the dorsal, which is the back of the wrist, the front of the wrist, and who would try manipulation in A&E? Are there any thoughts? Do we have any responses? Yeah, okay. So the vast majority of you would manipulate this fracture in theatre, and I think that's very reasonable in A&E, I think that's very reasonable. And what you have to ask yourself next is, how would you manipulate it? Would you manipulate it with a hematoma block, or would you manipulate it with a Beer's block, or would you want some formal sedation from one of the A&E guys? So then on to question 2. In a 70-year-old male, if you get a good reduction in theatre, in A&E, what would you then do? Would you manage it in a cast with an X-ray a week? Manage it in a cast for 4 weeks? Put a K-wire in it in theatre, or plan to fix it with a plate and screws? And this is something that you have to start thinking about more as you move up the grades, is what comes next after you've done the emergency management. Okay, great. I think that's all very reasonable, and I think that's what most people would do. And the results suggest that most people would manage it in a cast for a week and see what happens in this generation. Now, oh man, okay, things frozen again. So the important thing about managing things in a cast, which I want to sort of say to you, is that how you put a cast on is extremely important. And I often see cases like this that have been manipulated into a reasonable position, but the fingers can't move, the thumb can't move, and these patients do very, very badly. And most of the evidence suggests that you have to manipulate it into a cast where you leave the wrist in a neutral position and the fingers can move. And if it requires more than that to hold the fracture in a reasonable reduction, then you probably, manipulation is the wrong thing to do, and they probably need some surgical intervention, because a cast in deep flexion, ulnar deviation, results in pain, stiffness, CRPS, and loads of problems. So the next fracture we want to have a quick look at is, this is a younger patient. It's a 26-year-old guy that's fallen off his bike. Now, looking at this fracture, can we get the question 3 up? Is effectively the same situation. And I'm just asking who would cast this with a dorsal slab, who would cast it with a volar slab, who would use an above elbow cast, and who would try a manipulation. Okay, let's have a little look. Right, okay, this one's a bit more mixed, which is interesting. So 27% of you said you'd manage it in a dorsal slab, 24% you'd manage it in a volar slab, 6% in above elbow, and 42% would say you'd manipulate it, which is quite interesting. So we'll just pause briefly on this. This is a volar shear fracture. So it's a volarly unstable fracture. Sometimes people call these fractures Barton's fractures or Smith's fractures, and they're inherently unstable injuries. And they don't respond too well to manipulations. So generally with a volar shear fracture, unless it's very displaced, which this one isn't, I would put it in a plaster cast in a volar slab. If you want to manipulate it and hold it, you really need to put it in above elbow cast in supination. But the majority of the time, if they're neurovascularly intact and closed, I would place it in a volar slab in situ. So the next question is, what would your definitive management be for this? Would it be the same as last time? Cast, X-ray in a week, see in 4 weeks, cast off, K-wire fixation, or plan for plate fixation? Yeah, good. Now, the majority of you have gone for a plate fixation, which is good. This is, as I said, a volar shear fracture. It's inherently unstable and needs fixation. It can't be K-wired because it's the forces are all directed volarly, and you can't really put K-wires through the median nerve and radial artery. And as such, we generally fix these with a plate. So the next one is slightly more complex fracture configuration. But the questions are the same, right? So you're still managing this person in A&E. It's a higher energy injury in a 35-year-old chap. So question 5 is how would you manage this in A&E after you've done your ATLS protocol and examined for all these other things? Volar slab, dorsal slab, manipulation. We'll quickly move through these. Yeah, great. 85% of you said manipulates this fracture. It's just very displaced. If you imagine that the median nerve is going to be tented around a 90-degree angle, it's great to get these fractures manipulated early. And then on to definitive treatment options. And this is a little bit more complicated, but let's see what you guys think. So X-ray in a week, X-ray in 4 weeks, K-wires, plan for a volar plate, or plan for another type of fixation. By other type of fixation, I guess we're talking external fixation, bridge plating, or fragment-specific fixation. Good. All right. Well, that's interesting. About 50-50 think just you could manage this with a volar plate alone, and about 45% think other fixation may be required. Okay. So let's move on to this is a case we're going to use to illustrate a few points about wrist fractures. So this isn't anything to put out to the floor, but just have a quick look at this X-ray and think about how you would describe this if you were to phone your consultant over the phone or phone your senior reg to ask for advice. What features of this fracture are important to have in that discussion? So when we look at radiographs of the wrist, there are several parameters that we look at which are very well described. And I'm sorry if I'm going through things that you all know very well, but I think it's very important to run through this and get a really firm grasp of all of these ideas. And these include length, inclination, radial tilt, radial translation, as well as slightly more difficult things such as carpal alignment and the teardrop angle. Generally with fractures, and I would say this for hips and knees and ankles, I'd avoid eponymous names and just describe what you actually see. So for very basis part, you need to know what the carpal bones are, and I've labeled them just with the starting letters. But when you're looking at a wrist fracture, you can see a lot looking at the plain X-rays. So because there's a volar tilt on the wrist fracture, you can see the dorsal cortex when you look carefully very easily, and you can see the volar cortex, which I've marked in blue. You can see the distal radial ulnar joint and the ulnar styloid. And all these things you should be looking at when you're looking at your plain X-rays to take more information about the injuries. Now, we'll quickly run through these. The first is the radial length. Now, there's two ways to look at radial length. One is to look at the radial height, which is this calculation, which is from the highest point of the ulnar head to the tip of the styloid, and this is usually about 13 millimeters. The other one is to look at ulnar variance, which is a bit more difficult, and that looks at the average between the volar and the dorsal cortex, the middle point of that, and comparing it to the tip of the ulnar head. And most people, that's about 2 millimeters positive. You also look at radial inclination, which is again from the same point on the ulnar side, which is the midpoint between the volar and the dorsal cortex. And sorry, it hasn't come out too well on this, but actually that oblique line should go up to the radial styloid. I must have moved something on the slides. And that should be about 23 degrees. All right. You look at the volar tilt, and that's the line which is perpendicular to the axis of the radius, and another line which is drawn from the highest point of the dorsal cortex to the highest point of the volar cortex, and that angle is usually about 11 degrees. Now, the picture on the right is something that not many people know and not really people pay attention to, but I think this is extremely important, as it really is the key to getting your DRUJ stability. And if you get your radial translation right when you fix a wrist or when they're in a cast, then they very rarely have problems with their distal radial ulnar joint and ulnar stability. And how you look at that on X-rays intra-op and prior to surgery is to draw a line straight up the ulnar cortex of the radius, and this bisects the lunate. And ideally, 50% or more of the lunate should be ulnar to that line. And you can look on the right-hand side of the picture where there is significant radial translation, that much less than 50% of the lunate is radial to that line. And what that does is it detensions your distal radial ulnar ligaments and causes DRUJ instability. And if you got this right initially, it may be that the ulnar styloid fixation wouldn't have been required. The next thing, which is also very important, and I don't think we look at enough, is carpal alignment. Now, when you break your wrist, it's often in a direct impaction injury, and your carpus lines up very well with your distal radius. And there are two main ways to calculate carpal alignment, but it's often something you just eyeball and know that it doesn't look right. The first way is to draw a line along the axis of the capitate and another line along the long axis of the radius on the lateral view, and these should cross somewhere within the carpus. The other way that's been described is if you put a dot or a circle or a mark, like in the second picture, in the center of rotation of the capitate on a true lateral X-ray, that should line up with the volar cortex of the radius. So you can see on this case that we're discussing, where there is a mild fracture, that the capitate lines up completely with the lunate, which lines up with the radial shaft. So I don't have very many concerns, although there's a fracture on this patient, that there's any signs of carpal malalignment. And that's in comparison to the dorsally angulated one on the right, where there's significant carpal malalignment. The next thing to talk about is articular step. Now, this is something that we often get CTs for now, but you can usually appreciate on a plain film. And it's a pretty important factor in determining if people should have surgery, although the exact importance is disputed. If you look at the studies by Jupiter, it showed that in a young cohort of an average age of 27, within 7 years, 91% of them had radiographic arthritis if they had a greater than 2 millimeter articular step, whereas only 11% of them had radiographic arthritis if they had less than 2 millimeter gap. So getting your articular reduction is important, at least in terms of radiographic arthritis. How important radiographic arthritis is to patients is a bit more tricky and is disputed, and that's shown in the paper below, where out of a large cohort, the 40 patients that had intra-articular fractures with a long follow-up, so they were patients average age of 40 that were followed up for over 20 years. Only 1 out of 40 had to stop work because of the pain in their wrist, although a lot of them had some discomfort on exertion. So now, when we look at this fracture that we described before, we've now got the tools in the armory to be able to talk to someone on the phone and give them a lot more information. I mean, you can say they have an intra-articular fracture with greater than 2 millimeter step, they've lost height and inclination, and they're significantly dorsally angulated to around 60 degrees, and they've got carpal malalignment with the carpus falling off the back of the wrist. And by saying that, and by calculating some of those numbers, someone knows exactly what the sort of fracture is that you're dealing with. Then the next question is, how would you classify it? So there are lots of classifications. There's an AO classification, there's the Frykman Classification, which is the one that I commonly use. And there's also Mayo classifications and things, but the Frykman is very simple. It starts off with an extra-articular fracture as 1, then an extra-articular fracture involving the styloid as 2, and then you have intra-articular into the radiocarpal joint, and then involving the styloid, intra-articular into the DRUJ, then involving the styloid, intra-articular into both the radiocarpal joint and the distal radial ulnar joint, and then these when they involve the styloid. So effectively, all the even numbers involve the styloid. So we can go through, when describing our X-ray, the criteria we've already discussed, but then also go on to say that this is a Frykman 7 fracture that goes into the radiocarpal and distal radial ulnar joints. So that's all very well. Now we can describe an X-ray, but is there any guidance into when and where we should intervene and distal radius fractures. And I'd encourage you all to look at the BOAST guidance for the management of distal radius and older fractures. Now, they don't, in my eyes, there's some very good points in there, but actually it doesn't give us guidance on when to intervene. It simply says, in patients under 65, consider the things we've already discussed on variance, intra-articular step and dorsal tilt when making your decisions, but doesn't give us parameters of when to intervene. It also has fairly unhelpful things like intra-articular fractures should be treated within 72 hours, which in the public health system is nearly impossible. So the best paper, I think, for deciding when to intervene with distal radius fractures is this paper by McQueen that was published in the JBJS, the British volume in 2011. And it gives very clear guidance to when evidence-based guidance to when they think we should intervene. And it's a positive ulnar variance of 2 millimeters, a gap in the joint or articular step of 2 millimeters, when there's any carpal malalignment, when the dorsal tilt has gone from 11 degrees positive to neutral, or again, when there's an articular step of 2 millimeters. Now, I think dorsal tilt is a bit controversial, but most of the other markers, I think most people would agree with. I would also consider when there's any distal radial ulnar joint involvement, or when there's any marked radial translation. And this is partly because particularly distal radial ulnar joint involvement is something that's very difficult to correct further down the line. So if you have an extra-articular fracture that has a malunion, that's very easy to correct down the line if people have ongoing problems. But if you have a fracture that goes into the DRUJ, or there is significant radial translation, or in fact, if there's a big articular step, those things are all very difficult to correct further down the line. The other important thing to know is what the predictors of failure are. Now, we talked about managing fractures with a manipulation in A&E and then bringing them back for an X-ray a week, which is pretty common practice. And often it's done by A&E and bring them back for their first review. And what you have to decide is when looking at those fractures initially, do you think that the reduction is going to be maintained, or do you think it's just going to fall back into the original position? And if that's the case, are you best intervening early before that happens? And it's fairly well described that the main predictors of failure of your reduction are significant dorsal comminution, age over 60, female patients, the degree of initial displacement, and the presence of an ulnar fracture or DRUJ involvement. And the last one is controversial. Some papers show that is a predictor of failure, others are less convinced. But effectively, if you've got a very angulated distal radius fracture with dorsal comminution in a 60-year-old woman, the chances of the reduction being maintained at 2 weeks and 4 weeks are extremely low. There are big studies, and the draft paper will be quoted around hospitals in the UK and is widely discussed. And the outcomes of the draft study were in distal radius fractures, which are dorsal bending fractures, when they can be reduced anatomically in theatre, then fixation with K-wires has similar outcomes to fixation with locking plates, and it's much cheaper to use K-wires. Now, what it doesn't say is that all fractures should be treated with K-wires. In fact, they tried to recruit 12,500 patients, and I think much less were actually suitable. Let me just get the number so I'm not lying to you. I think it was, hang on, yeah, 230 or so were, no, sorry, 400 and something were recruited out of 12,000. And that's because a lot of the other ones either couldn't be reduced closed, were intra-articular, the surgeons thought they needed surgery. So if you have a simple distal radius fracture that you can reduce in theatre, then I think K-wires are very a reasonable option. So now the next stage, and this is when you're moving on to, becoming a registrar and having patients in theatre and starting to decide and look at fractures and thinking, how am I going to fix this fracture? What's my approach? And when you look at depth at these fractures, you can really start to see just on the plain films, and now we have CT, that there are common fragments that form. There is a radial column fracture, which is the styloid fracture, is number one. There's usually a dorsal wall fracture and a volar rim fracture. There's usually a volar ulnar corner, which is probably the key fracture because that's what you build most of your reduction off. And there's often a central depressed articular fragment. And modern fixation systems often have specific plates designed to target all of these bones. And when you look at the fracture that we've described, you can actually see all these fractures and fragments quite clearly just on the plain X-ray. And there are several things looking at this. If you look at the blue line, we said previously the line at the back is usually the dorsal cortex, but because the fracture is tilted so dorsally, the line at the back is actually the volar cortex in this case. And other fragments are marked on there. So when I'm looking at this plain X-ray, I look at the lateral and I see that there is a good volar chunk of bone that extends proximal to the watershed, and as such, it would be you could fix it with a standard plate. I also look at the styloid fragment, which looks relatively large, which means I should be able to fix that with a standard plate. But then I look at the dorsal fragment and think that's quite a large fragment as well. And the carpus seems to be moving with that dorsal fragment. So it may need to be augmented with a dorsal plate. And that's what I did with this fracture. We fixed it with a volar plate. I put a dorsal ulnar buttress plate on to try and catch that dorsal fragment. And the same is true for the other fragments as we talked about. If you see on the left, I've marked the different fragments for the volar shear fracture we talked about. And in this case, they had an extremely small styloid fracture that I couldn't catch with my volar plate. And as such, I put a wire form fragment specific plate onto that styloid fracture. And that was the key to this reduction. The more complex fracture is shown here. Now this, I put this up largely because it's the closest I've become to becoming a plastic surgeon using hundreds and hundreds of KYs, but also it shows that actually a systemic approach of building all the fractures up means that even in these very multi-fragmentary complex cases, it's often possible to fix them stably with intra-articular fixation and get early movement. And as we discussed previously, early movement is the key to these fractures doing well. I think a lot of people would have managed this with a bridge plate fixation, which is just a plate from the radius straight to the metacarpals, often with minimal internal fixation around the fracture to reduce the articular surface, and I think would have been a very reasonable choice. So now we're going to move on to scaphoid fractures, and scaphoid fractures are pretty important. We'll discuss that in a minute, but let's start off with question number 7. So just quite simply, what type of scaphoid fracture is this? Is it a proximal pole, a waist fracture, or a distal scaphoid fracture? Yeah, perfect. So yeah, as 88% of you said, this is a scaphoid waist fracture. Great. So then on to the next question, which I think is how would you definitively manage this? Would you go for a cast for 6 weeks, cast for 8 weeks or more, or with fixation? If this was your wrist, how would you have it managed? Now, this is a little bit controversial. Yeah, and that's shown out by the results that about half of you would fix it and half of you would manage it in a cast. Okay, so let's go on to the next quick slide. So you've decided to manage this fracture in a cast. How are you going to cast this person's wrist or splint this person's wrist? You're going to put them in a Futura splint with a thumb, without a thumb, a cast with a thumb, a cast with no thumb. You're now the A&E or the registrar on call having to make these decisions in clinic. Oh, right, so that's pretty much split across the board. So 30% say a Futura splint with a thumb, 3% say no thumb Futura splint, and about 30% say a cast with a thumb, 40% say a cast with no thumb. So very widely split on that. We'll talk about that in a little bit more detail further down the line. Okay. Oh, crashed again. Okay, so scaphoid fractures are important, right? You're going to see a huge amount of them in clinics. They affect young people. The implications of missing a scaphoid fracture are huge. They, for many reasons, including their blood supply, often don't heal. And then, as you can see by the table in the bottom, if they don't heal, you inevitably get arthritis in your wrists. Because of missed scaphoid fractures, we probably overtreat a huge amount of people. And because of the financial and legal claims, they're very common in exams and interviews. But despite all the problems with scaphoid fractures, they're very controversial, and there's lots of variable practices around the country. Variability in casting, as we've just talked about, imaging, surgery, how you rehab people and how you manage them if they don't heal is done very differently depending on your access to resources and the surgeons you have in your department. Now, what's important for you guys is to start to develop an algorithm, and a scaphoid fracture is not just a scaphoid fracture. It comes in a whole wide range of scenarios, from the undisplaced fractures to the minimally displaced ones, to the very displaced, to the proximal fractures. And that's how I divide mine up, and that's the algorithm I've developed over time, and we'll talk a bit about that today. But it's very important that you start thinking about these fractures in that way. How am I going to manage this, and what am I going to tell patients? So the bulk of our work is patients that come to fracture with a possible scaphoid fracture. And Dias did a big study of nearly 13,000 people who, 1,300 people came to fracture clinic with query scaphoid fractures, and he found 94% of them actually didn't have a fracture. So what do? We see them at 2 weeks. We take their cast off and we examine their wrists. And you can see from the table below that actually examination is not particularly sensitive or specific. If all of your tests are positive, then it's 100% sensitive. You're not going to miss any fractures. But there could be other things that are causing that pain. So examination on its own can't tell us. And actually, the further you get away from the injury, the less these findings are positive. So at 2 weeks, scaphoid fractures are often not that painful and not that tender. So we do x-rays, and it's very important to get 5 x-rays. And these are the classic x-rays you should always get. If they don't get 5 x-rays, they should go back and have another x-ray of their wrist, because it happens all the time where the one you don't have is the one where you can clearly see the fracture. But even this isn't 100% sensitive and only around 90% sensitive. And you often find yourself looking to see if you can see a fracture anywhere. So then there's the question of, where do you go from here? You're a bit worried that a patient may have a scaphoid fracture, and you can't exclude it from your examination or your x-rays. What investigations would you choose to order next? Great. So yeah, 30% limited sequence MRI, 30% full MRI, and 35% CT. Now, that's very interesting, and that really does highlight the variability in practice and resources that you get in the UK. Now, I'm glad that most people don't get bone scans anymore. They're not very good, with 25% false positive rates, which means we're over-treating a lot of patients, and there's a lot of radiation. And beyond that, they're actually quite difficult to organise. Ultrasound scan is better, or it's probably not even as good as x-rays, so we don't do that very often. And in terms of probably the gold standard is an MRI scan. It has the highest sensitivity and highest specificity. And it does pick up other injuries. So you often find that distal radius is broken, or there's a capitate fracture, or the trapezium is broken, or there's some other thing that can explain the patient's symptoms. But in many hospitals, this takes 3 to 4 weeks to get. And now you can get limited sequence MRIs, which take much less time, 5 to 10 minutes, and a lot of hospitals can get them quicker. And they give you one sequence, so your scaphoid will glow up if it's broken, but you can't accurately see if there's other injuries in the wrist as well. But that can buy you time because most other injuries don't need the same intensive treatment initially. A lot of people get CT scans, and I think if you get a fine slice CT scan of less than 1 millimeter or 1 millimeter slices, then that's pretty good. And I can often get a CT scan on the same day. So with normal or with a equivocal examination in X-rays, a CT scan that is normal, I find very reassuring. And I would often wouldn't discharge someone who has good clinical findings, but if that's negative, I think that's a very good first test. So now you've got this situation where you've got your 18-year-old coming into clinic, and you want to send them for their scan, but your scan's going to be three or 4 weeks away, or 2 or 3 weeks away. How are you going to immobilize them in the interim period? Do they get a cast? Do they get a splint? Can they take their splint off? Or do they not have any immobilization? Yeah, again, very, very even split. Most people seem to either want to put people in a Futura splint or in a below elbow cast. And I don't think there's a right and a wrong answer to this. I usually try to have this sort of shared decision-making policy where you talk to patients and you explain the scaphoid fractures, the risks of them not healing, the best treatment and how you would treat them. But actually, all it really does is make the patients more confused, because you can tell them that with all the imaging they've had, there's a 6% chance they actually have a fracture. If they do have a fracture, there's 1 in 10 people's fracture won't heal. But there's a high risk it doesn't heal if we let you move your wrist or if you go into a splint. But then there's a 94% chance you'll be in a cast and immobilize your wrist unnecessarily for at least 2 weeks, and see if they want to make the choice. Most people, I would say, choose to go into a Futura splint and decide to keep their wrist still for the first couple of weeks. But it's certainly not an easy decision for them or to explain to them. So now we're going to move on to minimally displaced scaphoid fractures. And this is another very controversial topic. And the sort of premise is, are there differences between union rates? What are the risks of fixing scaphoid fractures? If you fix it, can you move your wrist quicker? Can you return to work quicker? Can you return to sport quicker? And that's what people genuinely want to know. So a minimally displaced scaphoid fracture is within itself very different, and it really depends on where in the scaphoid you've broken. Now, the majority of scaphoid fractures, 77%, occur in the waist, okay? And if you manage them, 90% of them will go on to heal, and it usually takes around 8 weeks, okay? The tuberosity fractures, so the distal scaphoid fractures, a much lower percentage, and they almost always heal, nearly 100%, and they heal a lot quicker. And a lot of the reason for this is because of the blood supply to the scaphoid, which has 2 main arteries, both of which come off the radial artery. There's a dorsal and a volar branch, but all of them enter the scaphoid distal to the scaphoid ridge. Therefore, the further away, more proximal you come from the scaphoid waist, the less blood supply the fragments have. And that and a number of other reasons is why proximal fractures are less likely to heal. Now, they're much rarer. They are often hard to spot on plain X-rays, but there is a much lower union rate of 66%. And it usually takes a lot longer, around 14 weeks. And because of the low union rate and the long period of immobilization, people are generally much more aggressive with proximal pole scaphoid fractures in terms of getting them fixed. There are other risk factors that are important. You have to tell your patients to stop smoking. A lot of surgeons won't operate on non-unions in people who smoke because their chance of getting them to heal is significantly reduced. If they're displaced, the relative risk for non-union is much higher. So displaced fractures we're a lot more aggressive with. And a very important thing is, and I sort of hinted at this earlier, is the delay to immobilization. If you break your scaphoid, it's minimally displaced, and you go into a cast quickly, then your chance of union is higher. And 50% of those that don't heal were not immobilized in the first 4 weeks. Now, what evidence have we got to guide us? Now, there's lots of big studies about scaphoid waist fractures, not least the SWIFT study, which is an excellent study looking at 1,000 patients with minimally displaced scaphoid waist fractures. And that was published in the Lancet fairly recently. But most studies show that the difference between operative and non-operative rate healing in terms of union is there's very little difference. And some studies do show that return to work and sport is less if you fix it. But again, this is a bit controversial. The SWIFT trial, which is a UK-based trial, concluded that patients should be initially treated non-operatively, and there's no significant increase in non-union or difference in functional scores at 1 year. But it is important to look a little bit more into the data. And if you look, this is the results of the analysis at 12 and 52 weeks. And if you look at those, the percentage, the first column is those that are managed with a surgical fixation. The second column is those that are managed in a cast. And the third column is the total numbers. And even at 12 weeks, the amount of healed or almost fully healed is much higher in the group that were fixed. And if you look at the non-union rate of those that were fixed, it's 0% in those that they managed to follow up, as opposed to 5% in those that were managed in a cast. And one of the reasons they concluded that there was no difference at 52 weeks is because those fractures that were managed in a cast went on to have surgery for non-unions early. And actually 17 out of 195 patients that were managed conservatively were transferred and had surgery, but still analysed in the intention not to treat group. It also shows within the data that those that were managed operatively usually weren't immobilised post-operatively, so they got their wrists moving a lot quicker. So they had their operation and they're either straight into a splint or moved their wrist immediately, as opposed to having nearly 7 weeks in a cast. Now, for a lot of people, 7 weeks in a cast is not a big deal, but for me included, if I had a minimally displaced scaphoid waist fracture, I'd probably have it fixed because I think I could be back at work within a couple of weeks. But it's not a benign operation, and it did show that on CT scans, and all patients had a CT at 52 weeks, showed that 65% of patients had screws penetrating the cortex, either proximally, distally, or into the radiocapitate joint. And 26 of those, so a quarter of people fixed, had screws that were prominent by 2 millimeters, and 4% of people had to have the screws removed because of this prominence. Now, we talked a bit about casts earlier. So there is no evidence that immobilizing people in a cast with a thumb has any effect on union. Now, scaphoid fractures often used to be managed above elbow, but there's no evidence, and that was to control rotation, that supination of the forearm affects scaphoid movement. And also there's no evidence that makes any difference if you have the wrist flexed or extended. So essentially, I put them in a below elbow cast in neutral with no thumb. And I think the difference in terms of hand function from having your thumb to be able to use is enormous, and patients are a lot happier to have a cast with a thumb, with no thumb. So what are the indications for surgery? So as we've already discussed, all the studies looking at minimally displaced fractures and non-operative are on those with less than 2 millimeters gap. So that infers that greater than 2 millimeters gap should probably be fixed. Patients with a humpback deformity or a significant increase in the intrascaphoid angle of greater than 35 degrees should be fixed. Proximal pole fractures, unstable fractures, so those that are associated with a peri-lunate dislocation, and controversially, those that are delayed, or those in smokers, or those that have higher relative risk of going on to non-union, people would consider fixing. And then how do we fix scaphoid fractures? Now, there's 2 common open approaches. So there's the volar approach, and often you use a Garcia Elias flap to reflect the capsule, and that's really good for treating waist fractures and distal fractures, and particularly those with a humpback deformity. And that's sort of shown in this picture at the top. is if you've got a humpback deformity, it's much easier to open that up and graft into it if you're attacking it from the compression side, which is from the volar side, than it is from the tension side, which is on the back. So I generally approach those fractures with a volar approach. The dorsal approach is very useful, particularly for proximal pole fractures, because it's very difficult to visualize proximal pole fractures from a volar approach. For the minimally displaced ones, particularly early, you can do a percutaneous fixation, and you can go from the volar or the dorsal aspect of the wrist for a percutaneous approach. But I'd encourage you, if you're going to go dorsally, to make a mini open incision so you can see the extensors, particularly EPL, to make sure you don't damage it. And increasingly popular is arthroscopic approaches to the scaphoid, which sounds very tricky, but actually, particularly for waist fractures, it's relatively straightforward through the midcarpal arthroscopy ports. So over time, this is my algorithm that I've developed. So in the query fracture patients, they get a sprint and they come to a fracture clinic. They get an examination and X-ray at 2 weeks, and that will show that they either have an underspaced fracture, which they then move down the underspaced algorithm, or there's ongoing concern. There's ongoing concern, they stay in a splint, and we try and get a limited sequence MRI scan, which we can usually get within a week. If they have an underspaced fracture, we discuss operative fixation and the pros and cons, but the preference, if there's indecision, would be to go for a cast with no thumb. I then do a fairly early CT scan at 6 to 8 weeks to see if there is bridging callus. If there's bridging callus at CT scan at 6 weeks, then they're going to go on to heal. And if they're going to go on to heal, then they can continue their non-operative management. If there is no bridging callus on a CT scan at around 6 weeks, then I think they're likely to progress to a non-union, and I fix them early at this stage. So then, unstable fractures, the ones we've discussed, so proximal poles, unstable, very displaced, they get a CT and they get fixed. And the non-unions, we're not going to discuss non-unions about the remit of this talk, but effectively they get a CT plus or minus an MRI, but usually just a CT, and we discuss operative fixation unless there's degenerative changes. So lastly, and we'll try and get through this to give Kalpesh a go, we're going to talk a bit about carpal instability. So carpal instability is something that's really common in interviews. I think I got it in my ST3 interviews, and it's something that you don't see very often, particularly if you don't work in trauma units. So these X-rays show carpal dislocations. I just want people's thoughts about whether this is a lunate dislocation or a peri-lunate dislocation. But if you've got no idea, it's fair, right? So let's quickly answer this. Okay, 50-50. All right, we'll talk about that. And the next question is this is again straight away for a question. There's other terms that you'll hear bandied around. So is this one a greater arc injury or a lesser arc injury, or do you have no idea? Oh, hello. Okay, so yeah, 55% say greater arc and 27% say lesser arc, 20% not sure, which is, I think, pretty fair. Okay, so let's talk about this. We're going to run through the sort of key words and phrases and things to think about in these cases. Okay, so this is the question you'll get asked in your interview or in exams. They say it's 10 o'clock. You're the on-call registrar. It's a 25-year-old in a motorcycle accident, comes in complaining of wrist pain. And they'll ask you what your principles are. You'll go through your ATLS and you'll go through your examination. And when you go through your examination, it will be a closed injury, and they'll tell you that the patient has median nerve symptoms, and they'll ask you what you're going to do about the median nerve symptoms. To which you'll say, after informed consent, I will try to do a manipulation to reduce the dislocation. And then they'll ask you, firstly, what the diagnosis is, secondly, how you're going to reduce it, And then lastly, what would you do if you can't reduce it at 10 p.m? All right. So let's talk a little bit about a few principles and a few key points. So the one on the left-hand side is a peri-lunate dislocation. And the reason it's a peri-lunate dislocation is because the lunate is still sat in the radial, in the radius. Whereas if you look at the one on the right, the lunate's been completely spat out volarly into the space of Peri, and it's actually the capitate that's really sat in the radial fossa. Okay, so the one on the left is peri, so everything is dislocated around the lunate, and the one on the right is a lunate dislocation because the lunate has come out. A greater arc injury is an injury that involves the bone. So the injury and the force goes through the bone as opposed to all the way through a ligamentous path. So on the one on the right, on the left, that's a trans-scaphoid peri-lunate dislocation because the force has gone through the scaphoid, and you can see the scaphoid is injured. That's a type of greater arc injury. And the one on the right has gone through the radial styloid and it's gone through the lunate. So that's a trans-styloid, trans-scaphoid peri-lunate dislocation. So all of these things show you've got a good idea of what's going on if these questions are ever asked. Okay. The next thing that it's important to mention, and this is what you should do whenever you look at a wrist X-ray, is look at all the things we've already discussed: high inclination, the DIUJ, the radial tilt, but also you've got to look at the carpus. And Gilula described 3 lines which go along the proximal row and between the carpal rows, and that should be smooth. And if those lines are smooth, there's very unlikely to be a carpal injury. Now, if you look at the previous picture on the right, which we've already discussed, and you look at Gilula's lines, you can see particularly lines 1 and 2 show significant disruption to the proximal carpal row, indicative of either a lunate or a peri-lunate problem. This injury was described a long time ago by Mayfield, and it's got a very well described passage for the force. So Mayfield really described a lunate and peri-lunate, which is as a purely ligamentous injury. It goes initially through the scaphoid lunate ligament, and that's a scaphoid lunate ligament injury. You commonly see that with diastasis, but then through the lunate capitate joint, then through the lunate triquetral ligament, before going through the radiocarpal ligaments and causing the lunate to dislocate. So when you're describing these, you can say that this Gilula's lines are disrupted, it's a lunate dislocation, and I classify it as being a grade 4 Mayfield classification because there's evidence that the lunate has dislocated, and there must be injuries to the scapholunate ligaments, the lunate capitate joint, and to the triquetral ligaments. So this is your reduction technique. So what you do, and we had one of these 2 weeks ago, is you put them in the finger traps, you give them some sedation and pain control, and you let their hand hang for a little while. All right, you go back and see them a few minutes later and put your thumb firmly on the lunate, which is pretty much where your carpal tunnel is. And like with most fractures, with traction, you exaggerate the deformity before bringing the hand over the top. Now, I think it's reasonable to have 1 or 2 goes at this, but don't try this for hours, and you don't want to be pressing very hard on the front of the wrist because you're pressing directly on the median nerve into the dislocated bone. And you can turn someone from having a worse neurological injury if you do too much. But it usually is possible, and it usually takes the heat out of the situation. So if you reduce their dislocation, you put them in a cast and then you elevate them overnight, often the median nerve significantly improves. So if it doesn't reduce, so this is the scenario we discussed. If it doesn't reduce, the first thing you do is you escalate it to your boss, and you start arranging a theatre space. When the patient goes to the theatre, you make sure they're properly paralyzed and relaxed, and then you try again to do a closed reduction. If you can do a closed reduction, then that's fine. Then you put them in a cast and elevate it. If not, you do an extended carpal tunnel decompression to reduce the dislocation. Then you can wash it, close the skin, put them in a cast and elevate it, and leave it for a hand surgeon to do a formal reconstruction in daylight hours on another day. And in terms of definitive reconstruction, it's a bit out of the remit of this talk, but And there's lots of differences again between how people reconstruct it. This is what I do. I do a volar and a dorsal approach. Through the volar approach, I repair the lunotriquetral ligament, and through the dorsal approach, I do the scapholunate ligament or the scaphoid, and then I held that reduction with K-wires for around 8 weeks. And I always tell people pre-operatively that they're going to lose a significant amount of movement in their wrist, around 50%. Often they do a bit better than that, but that's roughly what I tell them before their surgery. So now, in your interviews, if you get this scenario, you'll be able to smash it with your knowledge of Mayfield and Gilula's classification. Great. Let's move on to Kalpesh, shall we? Unless anyone has any questions now.
I don't think we have any questions. So thank you very much, Mr. Williams.